Thank you very much. Can everybody see my screen?
Yeah.
Excellent. So thank you for that lovely introduction. Thank you for the invitation. It's my great pleasure to speak to you. Without further ado, as the title on the first slide suggests, I'm going to be talking about radiopharmaceuticals for targeted therapy, practical applications, and future prospects. And for anyone who doesn't know me, I am indeed an associate professor in both the departments of radiology and medicine at McMaster University. Now, I always include the logo of the Dana-Farber Cancer Center and Brigham and Women's on my talks that have anything to do with PET. And the reason for that is that I did my fellowship and then was on staff there. And there was a lovely man by the name of David Israel, who originally hailed from Winnipeg, but I had to go to Boston to find him. And he taught me most of what I know about PET. And he has since passed away, but I dedicate any PET lecture I will ever give to him. So without further ado, let me continue here. Let's see. There we go. I thought I'd start off with a little bit of background, then some recent advances, and then some future prospects. So when we talk about targeted radionuclide therapy, we often shorten it to TRT. And basically, it means the use of one or more radionuclides for targeted therapy at cellular or molecular levels. And it leads to cell death by 1, direct radiation, 2, crossfire, and 3, the bystander effect. It's actually been used for many, many years because we have been imaging and treating thyroid disease using radioactive iodine since the 1940s. In fact, they celebrated their 75th anniversary not long ago. Probably the most recent TRT on the block is radium-223 dichloride. Now, I say recent, although one of the greatest women in science, Marie Curie, won a Nobel Prize in terms of looking at radium. So what is radium-223? It's an alpha-emitting radiopharmaceutical. It's the first TRT that was shown to extend life in men with castrate-resistant prostate cancer. There are some adverse effects, but they tend not to be severe, and long-term complications are relatively uncommon. I've here referenced the ALSIMCA trial, which was published in 2013 in the New England Journal of Medicine, which basically showed that radium could help not only with pain management, but also with extending life in men with castrate-resistant disease that was metastatic to bone. And this is just showing you a bone scan. It's a TEC MDP skeletal scintigraphy study done pre and post radium dichloride therapy. And you can see the sites of disease appear to be improving or becoming less intense post-therapy. So you can see there was intense uptake at a site of disease in the shoulder that has since significantly improved. We also talk a little bit about radioimmunotherapy, often abbreviated to RIT. That's the use of radio-labeled monoclonal antibodies for targeted therapy, which leads to cell death by apoptosis from radiation exposure and host immune response against target cells, including apoptosis via signal transduction, complement-mediated and antibody-mediated cellular toxicity. There are really two big flavors of this. One, known more commonly by the name Zevalin, which is a radio-labeled anti-CD20 monoclonal antibody, and it was the first to receive FDA approval for the treatment of relapsed refractory low-grade follicular or transformed B-cell non-Hodgkin lymphoma back in 2002. It was very quickly followed by Bexar, which is a radio-labeled anti-CD20 monoclonal antibody also used for the treatment of non-Hodgkin lymphoma. In general, radionuclides that emit alpha or beta particles are preferred for the treatment of bulky tumors, although Auger electrons can be helpful for small tumors. So when we talk about this whole area of theranostics or theragnostics, which is basically imaging and then treating what you see on your images that are generated using radiopharmaceuticals, which are just radioactive drugs that have met regulations for administration to patients. Is this historical? Is it a modern day breakthrough? Well, I would argue that radiopharmaceuticals have been used for years in terms of predicting therapeutic response and targeting disease, as well as targeted radionuclide therapy, the best example being radioactive iodine for targeting thyroid disease. However, there is a new emphasis on a personalized approach to medical care, which includes baseline and follow-up assessment as well as dosimetry to maximize the effective therapy while limiting toxicity. However, this can be challenging to implement and fairly expensive because it usually requires several patient visits to do the dosimetry and to decide exactly how much radioactivity should you give the patient to get the best possible effect with the least toxicity. So there are several unmet clinical needs that require our resourcefulness. These include multidisciplinary awareness of what's out there, what can be used, and for what purpose, education and collaboration, as well as a practical approach to radiopharmaceutical manufacturing and delivery, assessing patient eligibility, as well as response to therapy, and of course, as always, addressing reimbursement issues. So, what are some of the recent advances in the field? Well, probably number one and foremost, you have to think about prostate cancer imaging and therapy. So, what are in our tool of imaging tricks that we can use in terms of imaging men with prostate cancer? Well, for many years, we relied on transrectal ultrasound in men suspected of prostate cancer after doing your PSA and your digital rectal exam. You typically did a truss with biopsy as the next step, or a transrectal ultrasound with biopsy. MRI is becoming more and more popular, both in terms of itself alone and MRI-guided prostate gland biopsy. In general, it's particularly helpful for men with a negative truss biopsy and an elevated PSA. One, to inform biopsy and stage men with prostate cancer, particularly intermediate to high grade risk of extension beyond the capsule. And two, to reevaluate men deemed to be suitable for active surveillance based on PSA truss and biopsy. CT bone scans to this day remain standard of care for looking for distant disease spread in men at risk of spread. And that includes both soft tissue and bone. Now, CT can look at both soft tissue and bone. Bone scan is particularly good for looking at changes in bone. So when is this particularly helpful? Well, this is just showing you an example of a 70-year-old man with prostate cancer, rising PSA. And you can see here a bone scan, which effectively has too much black stuff. And where everything is really a dark black, it suggests you have increased osteoblastic turnover. And the blasts that are turning over take up the radiopharmaceutical, incorporate it into the bone, and you get increased emission of radioactivity from those sites that you can then detect with a camera. If you look at the correlating CT, you have diffuse sclerotic bone disease, which is where you have the osteoblastic turnover. What's the problem with this? Well, the problem is really the mechanism by way this radiopharmaceutical works. What you're doing is you're looking at the osteoblastic turnover, which is taking up the radiopharmaceutical. So you're not imaging the tumor cells themselves, you're imaging the reaction of the bone to the tumor cells. That means you're starting to play a guessing game of what is going on at the site of disease. Is it a response to the disease? Is it a response to treatment? What exactly is happening? So what can we do? Well, we can look at patterns and say patterns are suggestive. Here, I've got too much black stuff, effectively, too much osteoblastic turnover, but it's focal in a rib. That's most commonly related to a traumatic rib fracture. Does it mean that it's not possible that's a site of metastatic disease that might be treated? No, it could be. It's just if you're playing a game of odds, it's more likely to be a fracture that's healing. If it's elongated uptake in a bone, on the other hand, it's a pattern that is far more suggestive of being metastatic disease. This is actually the scan that first got me interested in prostate cancer. I read it while I was at the Dana-Farber Cancer Institute. It was one of the first bone scans done in a man treated with XL184 or cabozantinib. And basically what happened was that in a span of 6 weeks, the bone scan went from looking like widespread osseous metastatic disease to no disease, nothing at all. And I got on the phone with the oncologist. I was like, what are you treating this man with? Have you found the miraculous cure for metastatic prostate cancer? I was so impressed that I went out to make sure we'd image the right patient. It didn't make sense. Well, it turns out that cabozantinib, not only does it treat prostate cancer, it actually treats the bone scan itself because it dampens down the osteoblastic turnover. And if you don't have much osteoblastic turnover, you don't get uptake on a bone scan. So it treats all sites of uptake on a bone scan. So you have to be very careful as to what is the mechanism of the uptake of the radiopharmaceutical, and therefore, what are you actually seeing on your imaging? This is particularly important when we look at all of these new therapies that have come on the market recently and that are available. The other thing is, what is the equipment that we have? So we say, enter onto the scene PET-CT and PET-MR. Well, when do you want PET-CT? When do you want PET-MR? What PET radiopharmaceutical do you want to use? We certainly have a whole host of different radiopharmaceuticals, several of which have been studied fairly extensively, while others are quite new. The optimal radiopharmaceutical has not yet been defined, although we're getting much closer to a time in which I think we know which way we're going to head. So just to give you an example of one of the radiopharmaceuticals that was fairly extensively studied, it's still being reviewed, and that is sodium fluoride. Now, it's an F18 labeled sodium fluoride. It's taken up again by osteoblastic turnover, but when you use it with PET or PET-CT, it's basically, to me, like looking at your routine bone scan, which is a tech-labeled MDP scintigraphy scan, imaged with a gamma camera, as compared to looking at your PET bone scan, which is, to me, like looking at a scan wearing my glasses versus not wearing my glasses. So if I look here at my routine standard of care bone scan, which would be a tech MDP scan obtained on a gamma camera, my colleague read this, and they really weren't sure whether there was metastatic disease there, was there degenerative change? It's really hard to tell. Now we look at the same patient, but this time they were imaged with a sodium fluoride bone scan, and there is no doubt in anyone's mind that there are sites of uptake, and the pattern of uptake is highly suspicious for metastatic disease. And to me, the comparison is like looking at this bone scan, but wearing my glasses. All of a sudden, I can see all the details. Not only that, but I get the CT because it's a PET-CT that goes with it. So I get additional information that helps me significantly distinguish where the sites of disease are. You might say, why don't we always use this? Well, the question is, in what cases does it actually add value? For example, if you know that a patient has widespread metastatic disease, does it make sense that we can see 100 versus 99 sites of disease? Well, it might not really matter. So it all becomes a question of what are the real indications? When do you really need to use a particular type of imaging versus another type of imaging? This is just to show the comparison of sodium fluoride versus FDG PET imaging in men with prostate cancer. Now, sodium fluoride is taken up at sites of osteoblastic turnover. So once again, it does not image the tumor itself. It images the reaction of the bone to the tumor. And you can actually see that quite nicely on this study, where there was a site of disease in the femur, and the uptake on the sodium fluoride bone scan or sodium fluoride PET is actually around the margin of the tumor where you have the osteoblastic turnover. You don't have much at the actual site of disease. What you're seeing, which is giving you this increased uptake, is the reaction specifically to the tumor at the margin of the tumor. In terms of FDG, FDG is just a sugar analog, and it is taken up at sites of disease, but it turns out that prostate cancer was not all created equal, and the majority of prostate cancers don't really like to take up glucose. So you often don't detect it on an FDG PET-CT scan. Now, do you see a little bit of uptake? Yes, you do. It's not intensely avid. So one, it's easy to miss. Oftentimes, it doesn't show much uptake at all, so people will argue the sensitivity is low. The issue is, however, that those prostate cancers that do take up FDG tend to be bad actors. So it does have prognostic implications, meaning the survival goes down if they are FDG avid. Enter the whole family of PSMA radiopharmaceuticals. These are the new kids on the block, and they have hit the whole medical community very, very hard. So they target PSMA, that's a type 2 transmembrane glycoprotein. It's expressed on cell surfaces of several different types of cells, but it's about 100-fold more common in prostate cancer cells. It's got a higher sensitivity and specificity than standard of care, and it commonly results in a change in management. It's also easy to do because there's basically no significant patient preparation. And it's exquisitely sensitive. So you can really see sites of disease you couldn't see before. Here you can see uptake in multiple lymph nodes below the diaphragm. You can also see uptake in the Burkitt node up in the supraclavicular fossa. And it's really hard to see that on CT. In fact, we were the first site to image a man with castrate-resistant prostate cancer using this radiopharmaceutical. And I believe it was our protocol that, with the help of Anne Goodbody and the CPDC, actually got this Radiopharmaceutical Health Canada approval initially. And it was thanks to the OICR that we had some funding to do this. Now, there are different ways that you can read these scans. You can read them just as sites suspicious for disease versus sites that are most likely to not reflect sites of disease. You can use various grading criteria. Some are referred to as PSMA RADs. Probably the other most common one is this MITNM classification. Most places still do not use a specific classification unless they're doing it for research purposes. And I would say the most important thing to keep in mind when you're analyzing these scans, either for research or non purposes, is that the fact that you have uptake does not make something prostate cancer. It doesn't matter what imaging you're looking at, you always have to go back to first principles. I showed you a couple of examples why you have to go back to first principles when you're looking at bone scans. Well, the same thing holds true with PET, regardless of what radiopharmaceutical you're using. And PSMA radiopharmaceuticals are no different. So in this case, we have intense uptake in the thyroid gland, not at a site of prostate cancer, it's at a site of thyroid cancer. Here we have intense uptake in the adrenal gland with an intensely avid nodule. This was actually an adrenal gland leiomyosarcoma with metastasis to the lung, most likely in a patient who also had prostate cancer. We know for sure that the uptake in the adrenal gland, because it's biopsy proven to be a leiomyosarcoma, the uptake in the lung, you can only guess that it's probably that. It would be highly unlikely for it to be related to the prostate cancer. The long and the short of it is that you always have to think, could this be something else? Just because it's PSMA avid does not make it malignant disease. When I said that from the literature, PSMA PET is exquisitely sensitive, it shows positive scans even when your PSA is very low. Obviously, the higher your PSA, the more likely you are to have a positive scan. The shorter the PSA doubling time, the more likely you are to have a positive scan. But it detects positive scans even when the PSA is very low. The other thing that comes up often as a question is, should you use the gallium labeled variety of PSMA radiopharmaceuticals or the F18 labeled variety of radiopharmaceuticals? You can really technically use either, and they're fairly similar. Generally, the F18 variety tends to have slightly improved image resolution. F18 has a longer half-life, so there's easier shipping. It may be more sensitive, which may be an issue, particularly in this era where we're looking at oligometastatic disease. And this is just showing you that you can really have a spectrum of disease. So probably there's not just one radiopharmaceutical to use, but multimodality imaging will be very helpful, where you look at both FDG and PSMA, or PSMA and another radiopharmaceutical. And some prostate cancers that might be particularly bad actors might be more FDG avid, but if you want to detect more sites of disease, you might want to use your PSMA radiopharmaceuticals. So it becomes a question of which radiopharmaceutical do you use, and then how do you use that information to treat these patients? So this was a study that was run by Glenn Bauman, also I think thanks to funding through the OICR, and it just shows basically that when you do PSMA PET, it results in a significant change in management in a number of patients, but it makes logical sense. If you detect more sites of disease, and they're really sites of disease, then you can treat the patient better because you know where all the disease sites are. The other thing that's very interesting is that if you have sites of disease that take up a PSMA radiopharmaceutical, maybe you can just swap out that F18 or the gallium-68 for a lutetium-177 radioactive atom and treat the sites of disease that you're imaging very, very specifically. We've shown that the therapy is tolerated. There are fairly few adverse events. PSA declines markedly in patients post this therapy. You do get imaging response, and you improve overall survival. Furthermore, that retreatment is a possibility. In fact, it was back in 2018 that lutetium PSMA as a therapy for prostate cancer won the Image of the Year through the Society of Nuclear Medicine and Molecular Imaging, because it was shown that in a small number of patients anyway, they might come into the hospital with widespread prostate cancer. You treat them with this, they walk out with nothing. It's amazing. Now, the question is, how long does that response live? What does it really mean? We're still in the early stages of this, but the changes can be remarkable. The other area I wanted to touch on, but I'll touch on it very briefly, is neuroendocrine tumor imaging. Neuroendocrine tumors are a heterogeneous group of malignancy. They're derived from primitive cells of the neural crest. They frequently involve the gastroenteropancreatic system. Most are indolent, some can be aggressive, and some can be therapy resistant. They're typically divided into those that are functional versus non-functional. And basically, the issue is that they overexpress somatostatin receptors, or those are referred to as SSTRs. And therefore, if you use somatostatin analogs, you can image them. Now, different analogs target different receptors. So that's a question of which one you want to use and why, and how much is going to be taken up at a site of disease. In our armamentarium of imaging, again, we have our usual suspects: ultrasound, CT, MRI, the old octreotide scans, and MIBG. But in general, gallium dotatate has taken the world a little bit by storm again, because it's showing that it just can detect sites of disease with higher sensitivity and specificity than anything that we've had to date. But it's also complementary with other radiopharmaceuticals. So it does change management, but the question is, what can you glean from all the imaging? And basically, I'm showing you some results from the literature just showing that it does change management, and also that it is complementary when you use different pharmaceuticals, because in fact, those neuroendocrine tumors that are better differentiated, so they look and behave more like neuroendocrine tumors, they tend to take up the radiopharmaceutical better. Those that are dedifferentiated, which tend to be the more aggressive ones, tend to take up FDG better, and they often don't take up your dotatate quite as well. So it becomes an interesting trade-off again in terms of what the radiopharmaceutical is showing and what's the best management, and how these patients will do in the long term. If you want to read more about how you do the study, this is a nice reference for it. The indications are typically to detect neuroendocrine tumors once you have a clinical suspicion of it. They're good for problem solving if you have suspicious lesions, or identifying a primary site of disease when you have known metastases on conventional imaging. They're good for assessing disease extent prior to definitive surgery, and they can be very helpful to suggest which patient will benefit by peptide receptor radionuclide therapy. And again, what we've done is we've taken the same radiopharmaceutical, we've just switched out the gallium for the lutetium. So now we're targeting what we saw in the gallium scan with lutetium as our therapy. And so how do you determine which patients are likely to respond? I said some of these tumors, when they're less well differentiated, they take up FDG. When they're better differentiated, they take up the gallium dotatate. So typically what we do is we grade the intensity of uptake of the gallium dotatate using this scale, which is called the Krenning Score. And if they intensely take up the radiopharmaceutical, you say, okay, they're probably going to respond to therapy with the lutetium variety of the radiopharmaceutical. Once again, similarly to anything, you have to remember that just because something takes up the radiopharmaceutical does not make it malignant. You always have to think of what can be your false positives, what can be your false negatives. What is your physiologic uptake? I've listed some common false positives. I've listed some reasons for false negatives, such as small tumors or variable activity. And I'm showing you an example here where a patient had a port. This is just inflammation. That lymph node was probably inflammatory. You've got uptake of gallium dotatate simply related to inflammation. It has nothing to do with your neuroendocrine tumor at all. The other thing to keep in mind is that low uptake, or the gallium dotatate, may suggest tumor dedifferentiation, not necessarily therapy response. So you always have to go back to first principles and think, what is really going on? And that's the detective work, and that's what I love about imaging. PRRT therapy, that's just the idea that we can treat exactly what we see and we can target it beautifully. If you want to read more about the procedure for it, I've given you the reference for it. You can also do dosimetry to try and figure out exactly how much of this radiopharmaceutical should you give to know what is going to be the best effect with the least toxicity. Once again, that makes things a little bit more expensive. It means the patient has to come back. It means you have to do additional imaging. So we've talked a little bit about background. We've talked about recent advances. In terms of future prospects, I leave you with this. What do we need? We need to be able to identify the extent of local and metastatic disease. We need to provide prognostic information and to reliably assess the impact of therapy. Where are we going? I think we're heading towards understanding the molecular biology of the disease and developing novel biological targets, both for imaging and therapy. And most recently, we're starting to implement this. So with that, I would like to say thank you to my friends and colleagues, and thank you for your attention. Thank you all.